Thank you very much for choosing the behavioral health session this morning. My name is Ioana Stăiculescu. I am a research specialist with the Center for Health Policy and with the Missouri Health Equity Collaborative. This morning, our panelists will have around 20-25 minutes each, and at the end of the 60 minutes, we can open the floor for discussion, comments, suggestions from you, so go ahead and take notes if you want. We have a wonderful group of speakers this morning. Our first speaker is Dr. Joe Parks. Dr. Parks serves as the Chief Clinical Officer for the Missouri Department of Mental Health in Jefferson City. He also holds a position of Distinguished Research Professor of Science at the University of Missouri in St. Louis, and he is the Director of the Missouri Institute of Mental Health. He also serves as the Clinical Assistant Professor of Psychiatry at the University of Missouri in Columbia, and the President of the Medical Directors Council of the National Association of State Mental Health Program Directors. Dr. Parks practices psychiatry on an outpatient basis at the Family Health Center, which is a federally funded community health center established to expand services to uninsured and underinsured patients in the Columbia area. Our second speaker today is Dr. Paul Thomlinson. He is the Vice President of Research and Quality Assurance, as well as the Corporate Integrity Officer at Burrell Center. Dr. Thomlinson is a licensed psychologist with specialties in industrial, organizational, clinical, and experimental psychology. He's also a member of faculty of several universities, and is a regular contributor to the professional literature. And our last but not least, we have Jeff Lubsen. Mr. Lubsen is completing the clinical portion of his master's degree in mental health counseling and will continue his education with a PhD in clinical mental health counseling education. Jeff has over 4,000 hours of volunteer community health service working with diverse ethnic, racial, sexual, and spiritual populations. He's also the organizer of the LGBT Affirmative Therapists Guild of Greater Kansas City. The Guild is a grassroots organization of psychologists, social workers, and counselors who offers support and resources for sexual minorities. The Guild's website, which is lgbtguild.com, serves as a referral and resource center for those seeking LGBT affirmative healthcare, as well as an educational resource for local providers who work with LGBT clients. And please join me in welcoming our panelists this morning. We have a lot of topics to discuss, so without further delay, we can please welcome our first speaker, Dr. Parks. Thank you. You can use this one to go forward.
Okay. Thank you. It's a pleasure to be here today. Let's see if this detaches. I like to move around. How are y'all doing this morning? Good? Has it been good so far? Thanks for staying. So I'm going to be talking about the increased morbidity and mortality associated with serious mental illness. By that I mean conditions like bipolar disorder, schizophrenia, recurrent major depression, post-traumatic stress disorder, and some of the severer forms of anxiety disorder. This increased mortality is largely due to preventable medical conditions, and I'll show you the data reflecting that. There's higher rates of metabolic disorders, cardiovascular disease, diabetes, and there's higher prevalence of modifiable risk factors like obesity and smoking that really are outrunning the epidemics of obesity and diabetes that I'm sure you're aware of in the general population. Many of the psychiatric medications used to treat mental illness contribute to risk, primarily by increasing weight. And I'll show you data also demonstrating that people with serious mental illness are significantly less likely to get the recommended treatment for chronic medical conditions, whether that's asthma, heart disease, arthritis, than non-seriously mentally ill populations. This epidemic, and it really is a tragic epidemic, came to light with publication almost 10 years ago, about 8-9 years ago, of a study that was done from 97 to 2000 that compared the standardized mortality ratios of people in the public mental health systems in 6 different states with their general population. Missouri was one of those states. We basically took the recorded death by death certificate of people that had been service in those years in the Department of Mental Health, and then compared them using actuarial standardized mortality ratios with the general population, adjusting for gender differences, age differences in the cohorts. We converted that to early premature years of life loss. So what this shows is that in general, across all these states, people in their public mental health systems were dying about 25 years earlier than the average age of death in the general population. This means people are dying in their mid-50s. This is sooner than people with HIV. People with serious mental illness have earlier loss of life than people with HIV. Is that a surprise to you? Are you surprised to hear that? Yeah. It surprised everybody, because the last time we had looked at it had been 15 years ago, and it was about 15 years premature loss of life in the previous cut that had been done in the previous data. Well, everybody said, my God, how could suicide be so horrible? What's killing these people? So there was a sub-analysis done of the cause of death. What this slide shows is you add up the years of life lost, YPLL, person years of life lost. So if you have somebody that was 25 that you expected to die at 78, they lost 53 years. If there's somebody at 63 that you expected to die at 75 because they were a man instead of a woman, then that would be 22 years. So out of these over 1,800 deaths across the 6 states, there were almost 48,000 years of life lost. But only 10% of those are a result of suicide, with perhaps another 8% as accidental deaths, which could include some suicides. About 30% of accidental deaths are probably suicides that have been coded that way. The majority are heart disease and other chronic medical illnesses. By far the leading killer of people with serious mental illness are chronic medical illnesses, primarily heart disease and other vascular diseases. This is especially surprising since in the general population, heart disease has been a huge public health victory. Between 1980 and 1995, the rate of coronary heart disease and stroke as a cause of death has dropped by 50% in the general population. Other deaths have stayed about even. This is a huge victory in public health. But if you look at mortality due to the same cause, cardiovascular disease, in the blue bars and all cause in the white bars, for people with schizophrenia during almost the same time period, you see mortality steadily increasing. So at a time when mortality drops by 50% in the general population, if you have schizophrenia, mortality is going up by about 100%. Would you call this an epidemic? It looks like an epidemic to me. Maine was not one of the original 6 states, those being Arizona, Missouri, Oklahoma, Rhode Island, Texas, and Utah. Maine had the brilliant idea that we should look at people before they die while we can still do something about it. So they looked at people in their Medicaid population and divided them into groups that had serious mental illness versus those that didn't. This also had the advantage of controlling for economic status. The major criticism of the earlier study is we were unable to control for economic status. And of course, poverty is strongly associated with premature death. But this is people in Medicaid. Nobody's got any money. You know, they're all pretty much the same amount of poor. But in every case, you see the people with serious mental illness have significantly higher portion of people with any given chronic medical illness, whether it's arthritides like skeletal connective disorders, emphysema, all of it's higher. All of it's higher. So the general causes, 88% of the deaths, excess deaths, and 83% of the premature years of life lost in people with serious mental illness are cardiovascular disease, diabetes, cancers, respiratory infectious diseases. The major killer of people with serious mental illness is medical illness. Really, people with mental illness are dying in large part due to higher involvement in the epidemics the general population faces, that being obesity and diabetes. I just told you our big public health victory was cardiovascular disease and stroke. Our big public health loss has been obesity and diabetes. Random medical news. It turns out that today, coffee is reported as causing depression in snails. Doesn't it seem like this watching the news at times? There's a new association. I'm showing this slide because I'm going to show you some associations. So I'm going to spin the wheel a few times. You'll drink to that. Yeah. Luckily, you're not a snail, and you're smiling, so we're all good. I'm going to talk a lot about metabolic syndrome, so I should explain what I mean by metabolic syndrome. If you have metabolic syndrome, if you have 3 of 5 risk factors or 3 of 5 clinical problems, that it being obesity is measured by either waist circumference or body mass index, high triglycerides, low levels of high-density cholesterol, the protective cholesterol, high blood pressure, or poor control of your blood glucose, being diabetic or pre-diabetic. If you have 3 of those 5, you have metabolic syndrome. The risk of coronary heart disease increases with metabolic syndrome in general, but these are also individual risk factors. If you have just one, if you just have high triglycerides but you aren't obese, you don't have hypertension, your glucose is fine, you're still about twice as likely to have coronary heart disease in the coming year as someone that doesn't. If you have 2 and you still don't have metabolic syndrome at 2, you're about 4 times as likely to have coronary heart disease. If you have 3, you're about 5 times as likely, which means you're about as likely to have a heart attack as somebody that's already had a heart attack. Metabolic syndrome is not small stuff. It's not just 3 risk factors. It adds up to significant cardiovascular risk. Now I want to show you the rates of metabolic syndrome in the general population as compared to people with schizophrenia. The NHANES is a national survey that's done every 3 to 5 years by the federal government to show the rates, the general health condition of the nation. So it is a randomly selected sample designed to represent the nation as a whole and represents kind of the average population. The CATIE column was a study that was done over about 5 years in the early, about 8 years ago, that looked at antipsychotic medications in people with schizophrenia. It was designed to compare the efficacy of different antipsychotic medications. But as part of that, they collected all this metabolic data. So it allows us to compare the rates of metabolic risk factors and metabolic syndrome in people with schizophrenia going to clinics that are organized enough, have their act together enough to participate in multi-site national studies, by and large academic centers. So these are people going to clinics that presumably have their act together and can give decent care. So in general, for the men, in the general population, about 1 in 5 men, 19%, have metabolic syndrome. It's about 1 in 4 women. That in itself is a horrible number. But for people with schizophrenia, the men, it's over 1 in 3, and for the women, it's 50%. You meet a woman with schizophrenia, there's a 50-50 chance she has metabolic syndrome. That's a high rate. You look at the individual risk factors, 50% of the men, about 50% in general for the men and the women have high triglycerides, low lipodensity protein, high blood pressure. There's really a population worth screening if you get a 50% catch rate. You know, this is the population you ought to screen. Actually asking, do you have schizophrenia, is a great way to screen people for chronic medical illnesses. What I want to point out is often, if you're a mental healthy person, how many people are out of the mental health field? Very few. Well, we got very excited about testing everybody for glucose when it came out that one of the major antipsychotics, Zyprexa, was associated with diabetes. But if you look at this, diabetes is a trailing indicator. It's the last thing to go. So the message I usually give to the mental healthy population providers is that they need to be looking at triglycerides, blood pressure, and cholesterol. Let's talk a little about obesity as a driver of this. As you know, that when it comes to being number 1, it's certainly true that we are the number 1 nation in terms of obesity. We are certainly beating the pants off of the rest of the world, even though we can hardly fit in our own pants anymore. Here's how obesity has increased in the U.S. from the early 80s, going up to around 10 or 14% by 1990, heading to 15 to 20% by 1993. Isn't this a scary slide? This is a really terrifying slide. Starting to hit the 20% by the turn of the millennium, heading up to 25% by 2005, and my data ends in 2005. And Missouri, did you notice we were leading the cut most of the time? I tell people when I lecture elsewhere that, you know, in Missouri, if it doesn't run too fast or struggle too hard, we'll dip it in batter and fry it. Then we'll usually dip it in butter before we eat it. Well, the risk of obesity among people with severe mental illness is higher than the general population. So they are the kind of the canary in the coal mine, the tip of the spear, if you will. If they've been more obese to begin with, they're even much more, and we're all gotten more obese. They've passed the medical risk points before we do. On average, people with depression are about 1.5 times more likely to be obese than those with aren't. With bipolar disorder, about twice as likely, and with schizophrenia, about 3.5 times more likely to be obese than the general population. The prevalence of metabolic syndrome increases with obesity, here measured by body mass index. Healthy people, people that are what's termed a healthy weight, only about 5% will have metabolic syndrome. People that are overweight, about 25%, and men and women over 50% if they are actually obese. So body weight is really the driver for metabolic syndrome. The dietary habits of people with serious mental illness are different than the general population. They eat larger quantities, they take in more calories, they're more likely to eat a diet that's low in fiber, higher in fat, fewer fruits and vegetables, similar to that seen in other low-income adults. This may be driven in a significant part by their poverty issues. They're also less likely to be physical active than the general population. People with serious mental illness in one study by Daumit were 1.5 times more likely to be inactive. In other studies by Emsley and Farmer, bipolar disorder 3 times more likely to be inactive, and depression twice as likely to be inactive. Higher calorie intake, lower activity, drives obesity. In addition, many of the medications that are prescribed for mental illness, particularly the antipsychotics, but also antidepressants and mood stabilizers, are associated with weight gain. But for each of these classes, there are some choices that have less weight gain. This illustrates some of the range of differences in weight gain with some common antipsychotics in use. With some of the higher risk ones, olanzapine, also known as Zyprexa, clozapine, you can gain on average in the first 10 weeks of taking it about 10 pounds, a pound a week. Is that not distressing? But there are choices. You see like ziprasidone, also known as Geodon, one of the older antipsychotics, Prolixin, generically named flurazepam, almost no weight gain. So this is something that we're working in the mental health field of having the prescribers talk with more frequently with the patients. What is the trade-off between hearing and seeing things versus putting on 10 pounds or a pound a week? I'll go on that slide in the interest of time. The patients, this is important to the individuals too. This is one person with mental illness who drew several pictures. First, that person on no meds, kind of a mess all over the place. And then they get on meds and they are feeling calm, they're not very active, and they're getting fat. And this person aspired to be active and thin, but still be on meds so they weren't a mess. So people want something better. The obesity drives the diabetes problem. This graph shows from 1990 to 2000 the correlation between the average body weight of the national population and the prevalence of diabetes. So in 1990, for the whole population in the U.S., the rate of diabetes was a little under 4.5. I mean, the average body weight was around 72, 73 kilograms. That would be around about 170 pounds. And the prevalence of diabetes was just under 5%. By 10 years later, in 2000, the average body weight is up by about 10, 12 pounds. And the prevalence of diabetes is up by about 3 times, about 50%, up to about 7%. Very highly correlated. And as I showed you the obesity increasing, I can show you diabetes trends increasing. Here's 1990. Here's 2000 with more states above 60%. This was the estimate for 2010 when these slides were produced in 2008. It's particularly important to get on metabolic syndrome because metabolic syndrome could also be thought as a pre-diabetic state. It's the kind of problems you get before you develop diabetes. And the problem with diabetes is it usually doesn't get diagnosed till you've had the problem for about 10 to 15 years. A lot of mental illness likes that also. This is the most complicated slide I'll show you. The red line is increasing insulin production. So when you get diabetes, in the years before you get diabetes, your cells become resistant to insulin. So your body makes more insulin. You know, the pancreas says, you know, they're just not getting it out there in the periphery, chuck out more insulin. The rising blue line is insulin resistance. Your cells saying, I don't care if there's insulin here, I ain't going to get rid of the sugar. So for a while, the pancreas flogs the body by creating more insulin even though it's resistant. Finally, the pancreas poops out. It can't keep on producing that much, and that's when the green line, the blood glucose, starts going up. So at the point of diagnosis, when your blood sugar, when you actually get diagnosed, you've been having changes going on for 15 years already. This is evidenced by at the point of diagnosis, people newly diagnosed by diabetes, 4% have high urine protein. That's evidence of kidney damage. About 8% have reduced reflexes, which are evidence of nerve damage. About 12% have low foot pulses. If there's enough crud in your arteries that I can't feel the pulse in your foot, that means there's crud in the arteries around your heart and your brain also, and you're at higher risk for stroke. About 17% have EKG changes consistent with diabetic and conduction difficulties, and almost 1 in 5 have retinal changes, the early stages of diabetic blindness. At the point of diagnosis, there's already been significant end organ damage, which is why it's important to attend to metabolic syndrome. Diabetes is also a significant cardiovascular disease risk equivalent. Actually, having diabetes makes you about as likely to have a heart attack as someone that's already had a prior heart attack. So for people without prior heart attack, there's about a 3.5% risk over the coming 10 years of having a heart attack. If you had a heart attack, there's about a 1 in 5 risk. With diabetes, making it about equivalent to having already had a heart attack ahead of time. So I've told you, people with mental illness are more likely to be obese, more likely to be diabetic. They die mostly to cardiovascular disease. Their rates have been rising in the previous years. This is also driven by smoking. People with mental illness smoke a lot. The average prevalence of smoking in people with mental illness, depending on the study, is 50% to 88%, averaging around 2/3 to 3/4, compared to the US prevalence of 25%. People with mental illness often inhale deeper and hold the smoke longer, and in some studies are able to achieve twice the nicotine levels of other people. 44% of all the cigarettes smoked in the US are smoked by people with mental illness. If you want to do smoking cessation, you need to be focusing on people with mental illness and substance abuse disorders because that's where they are. Actually, the best screening question you could use in the ER for substance abuse and mental illness is, do you smoke cigarettes? If they say yes, there's a 2 out of 3 chance they have had or will have a mental illness or substance use disorder. So, the overall reasons for increased mortality in major mental illness: lipid abnormalities, diabetes, hypertension, metabolic syndrome, inactivity, decreased adherence. I've gone over some problems. I want to inspire you by pointing out no matter how great and destructive your problems seem now, you remember you've only seen the tip of them. Which brings me up to problems with access to health care. People with serious mental illness have less access to health care than the general population. How many of you have more trouble accessing health care than 10 years ago? You know, it's complicated. I spend hours going over my daughter's insurance receipts and getting the prior authorizations. You need to have organizational skill, persistence, concentration, and good energy to get health care in this silly country. And you know, mental illness interferes with executive functions like persistence, memory, organization, and staying on task. I have a hard time doing it. I'm a professional administrator. So they end up overusing emergency and specialty care. Emergency care, you know, people really want health care delivered like Walmart sells products. They want to go in whenever and get whatever they want on demand, immediately, cheap off a shelf. The only place you can get that is the ER, which is why the ERs are increasingly popular, because they give health care like Walmart. And that's what the customer wants, but that's not how we're organized. But there's more emergency care, more specialty care, lower rates of primary care, less routine testing, horrible dental problems, and not much coordination between primary care and the mental health specialty providers. Ben Druss, down at the Carter Center, did a wonderful study. He looked at people in California Medicare, 88,000. These were people 65 age and older. They were identified to be in the study by having had a heart attack. That was the entry point in the study. The hospital knew they were sick. They had entered a diagnosis of having a heart attack on a claim. When they looked at these people over subsequent time, if they had any mental disorder, they were 19% more likely to die, 34% more likely if they had schizophrenia, and this was explained almost entirely by not getting the usual routine care you should after a heart attack. This population, if they were severely mentally ill, were less likely than the non-mentally ill to be screened or treated for dyslipidemia, for hyperglycemia, for hypertension. They were less likely to get an angioplasty or a coronary artery bypass. They were less likely to be prescribed thrombolytics, aspirin, beta blockers, the usual medications you get after a heart attack, and that accounted for the bulk of the premature mortality. These are people that were known to have a heart attack that did not get the routine recommended care, resulting in 20 to 30% to one-third greater mortality. This is really bad. This is bad practice. This is negligent patient management. So I want to remind you of that Katie study. Remember I showed you that about 50% of these people with schizophrenia had high triglycerides, poor blood pressure control, or problems with their glucose? Well, when they looked at were they getting treatment, 88% of the people with dyslipidemia were not getting a statin. 62% of the hypertensives were not getting an antihypertensive medication. University clinics that can do research failed to identify in 50% and failed to treat in 62%. This is negligent care. This is negligence. 30% of those with poor glucose control were not getting any treatment for their diabetes. 30% miss rate for diabetes. So a few observations. These are significant preventable causes. There are lifestyle things like smoking and inactivity. There are medication problems. Inattention by the treatment system is a huge problem. Failure when your best just isn't good enough. The mentally ill are a health disparities population. Not by reason of they're not getting mental health treatment. They have problems there also. But they are a chronic medical illness disparities population with earlier expected death than people with HIV. Thank you.
Thank you very much, Dr. Parks. And now please join me in welcoming our second speaker, Dr. Thomlinson. Thank you.
Thank you kindly. I have the magic iPhone, which will tell me in 20 minutes to shut up. Starting now. Thank you for this opportunity. It's good to be here. I'm going to do the same thing Joe did. I'm frankly shocked, however, that the medical director for the Department of Mental Health would perpetuate such stereotypes as the rural snail who's depressed and the coffee addict. I was flummoxed, as well as the rural stereotype that we like to go around, deep frying roadkill. And Joe, what were you thinking? So thank you all very much for the opportunity. Greetings from Burrell Behavioral Health. We are a fairly large behavioral health organization going back about 35 years. We have 2 service areas, one based here in Columbia and surrounding counties, 10-county region in central Missouri and 7-county region in southwest Missouri, with Springfield being the sort of urban hub. So that tells you that we straddle sort of urban and rural areas. And I've sort of tried to rip out an isomorphic outfit today where this is how we dress in the city up top, and the jeans and boots, this is how we dress in the country. So just a visual representation to help you with that. We try to really, be culturally competent across the board. So I fear that some of what I'm going to say today is going to be in the category of what we call the BFO, the blinding flash of the obvious in many ways. But nonetheless, and I also believe I believe C.S. Lewis said something like, we usually don't need to be taught much of anything, but we need to be reminded over and over of what's true. And so most of what I'm going to say today is true, and it's your job to figure out what's what. So the first thing is that about 60% of rural residents live in mental health shortage areas. No one's surprised by this. And 65% or so receive their mental health care from primary care providers. That's according to Gale and Lambert. But as we also know, the vast majority of behavioral health services, in particular psychiatry, are available only in urban areas. And again, as such, no surprise that there are access issues for folks who live in rural areas with regard to behavioral health. This is a bunch of sort of support for what I just said as well. There's really probably not a lot of need to continue to beat that horse. But it is indeed a continual issue for providers in rural communities or who have responsibility for provision of care in rural communities to find ways and means of meeting the extraordinary needs that are out there, including issues of high suicide rates. In my role as a QA/QI guy for this center, just think about Joe's presentation. I mean, it's remarkable. I mean, of course, I see every incident reports that comes through the center, and it wasn't really a surprise when Joe's edited paper came out a few years ago with the 25-year mortality gap, because I saw that stuff all the time. You know, I'd see those incident reports, the death notices coming through with folks with schizophrenia and other serious mental illnesses. You know, and I ceased to be surprised when I saw the ages, 45, 37, 52. It was extraordinary, and again, not surprising when you look at what the data are telling us. But some of that obviously also has to do with this high suicide rate, although, as Joe also took pains to point out, that was controlled for in the study he was talking about. But nonetheless, the suicide rate among rural males is higher than among urban counterparts. So again, lots of information here to basically make the point that access is a problem. And prevalence, of course, the likelihood of mental disorder in the general population, 20% of children, adolescents, 9 to 17, as many as 25% of those 65 and older. And the prevalence is roughly equivalent from most studies in urban and rural areas. However, of course, there are some notable exceptions. When you look at what causes, and again with the theme of the conference, in terms of equity differences, poverty, age, being African American, and living in a rural area have all been associated with lower likelihood of receiving mental health care when it's needed. I'm going to talk very quickly about what have been identified in the literature as the primary barriers to receiving care. And I'll talk a little bit more about some than others, very likely. But those are the big four. And I always like to let clients speak too. And this is kind of interesting. My counselor said, mental disorders just like diabetes. When diabetes, you have to take medicine. With mental disorders, you take medicine. Well, that's great and wonderful, she said. Now tell the public that. And of course, that's sort of a wonderful exemplar. If we were doing qualitative research, that would be a great pull quote to illustrate this theme of stigma and cultural issues related to the treatment of mental disorders, or even seeking care for a mental disorder. Social stigma and mental illness continues to be a fundamental primary barrier. You probably read that over and over. It's true. It continues to be true, and we haven't made a lot of progress, at least progress that I've been able to observe in the last 10 or 15 years. Mistrust of certain members of the healthcare profession, even those who wear jeans and boots, sometimes are continue to be mistrusted. There is a cultural ethic. I mean, you know, we are in the clasp of the buckle of the Bible Belt, and we are also, you know, in the Ozarkian plateau there, and we have all these amazing sort of 150, 200-year-old traditions and cultures that people don't often see sort of very clearly. It's like the fish doesn't know that he's wet. You know, we're sort of immersed in this, and sometimes we don't see the extraordinary cultural ethic that sometimes prevents folks from showing up at our doors, including as some sort of cultural historians and cultural anthropologists who have studied the Ozarks culture, where our Southwest Missouri sort of operations are centered, is that there is an abiding mistrust of outsiders. And believe me, outsiders can be defined very, very broadly for an Ozarkian person. And the other really important cultural ethic that is sort of sometimes gets in the way is this idea of we take care of our own. We don't need help. We don't need anything from even, and again, as I said, broadly defined outsiders. We can take care of ourselves. This also has resulted in atrocities. And you might think I'm making it up when I tell you that there still are people, recent case where an adult person with mental illness lived in the shed, the tool shed, with no heat, no air conditioning, dirt floors, because we're just not going to have any of that mess. We don't admit to that, and we'll take care of it. And in their minds, at least, that was taking care of business. Or the little boy was raised in a dog crate for the first 4 or 5 years of his life that we had in treatment for a very long time. So anyway, I could go on and on about those. That comes from a very interesting, not to say that doesn't happen everywhere in some measure, but there are particular cultural ethics sometimes that prevent folks, and the natural isolation of rural areas can facilitate some of those kinds of horrors at times, unfortunately. Financing and reimbursement. This is not my bailiwick. I never claim to be a behavioral economist, but you don't have to be to see some of the issues, and Joe can speak eloquently for hours, and often does, about these issues that relate to essentially mechanisms that are suboptimal, shall we say, for getting funding to where it needs to be with regard to prescription medications, funding for support for evidence-based practices, targeting particular rural populations. It's one of the most fundamental economic principles, of course, supply and demand, and we find that the rural population sometimes doesn't get identified as a high demand population because there's less of them concentrated in one area. And that old saying about you never underestimate the power of lots of people sort of aggregating in one area and talking really loudly. Well, obviously, rural folks don't do that very well. In many cases. So sometimes there is a lack of advocacy for that, for making funding streams perhaps optimally responsive. Reimbursement problems with telehealth services, which is the closest thing to magic I'm going to talk about today a little bit. Funding systems that are complex, fragmented, etc. Structural and organizational issues, and there's a lot of overlap from these things. From the literature, though, we know very clearly that and from experience, trust me, we're recruiting for this stuff all the time. Insufficient communications among primary care providers and community health centers, and community mental health centers. And can I get an amen? Yes, I can. For anybody who's ever had any kind of experience with this, you'll know that is an ongoing issue. I was sort of flummoxed, a little bit blown away. We received some reports on our providers who provide care, psychiatrists who provide care to Medicare patients. This is lagging about a year, but we just got these reports. And would anybody hazard a guess when we look at the number of different physicians, number of providers that our Medicare patients have seen in that 1 year? Anybody want to guess what the average is? How many different providers? Close, 10 to 13. And, I'm just going to guess that they're not all talking to each other. Well, I don't have to guess. I know they're not. And, we sort of hope that at least one or two of them are. The ones that are actually prescribing the really life-altering, mind-altering drugs, that sort of thing. You're hoping that they're going to talk to each other. The ones that are prescribing things that cause metabolic syndrome in droves, maybe they should talk to each other. Well, oftentimes they don't, especially when there is this geographic spread that's emblematic of rural communities. There's a blinding flash of the obvious. Public transportation is kind of a problem in these sparsely populated areas, obviously, as is private transportation when gas costs $3.50 to $4 a gallon, and even when it doesn't. So a whole bunch of structural and organizational issues, as you can see. And a whole other slide of them that I don't only have time to talk about. But trust me when I tell you, there's a lot of them to address. Access and workforce issues, we have several things in the sort of in the pipeline to help address some of this I'm going to talk about very briefly. But lack of trained staff members, providers, clinicians, lack of availability for dual diagnosis treatment. We know that folks don't get better when they're dually diagnosed with mental illness and substance abuse. When they're treated in parallel fashion, they don't get better. They don't really get much better. When they're treated in a truly integrated fashion, the research shows they get better at a much higher rate. And it's really hard to do that and to have the sufficient sort of critical mass in rural regions to do that. We have great integrated dual disorders treatment programs in Springfield and Columbia, but if you can't get to one of those areas, then you're kind of out of luck at this point. Lack of financial incentives, lack of scholarships. Somebody was lamenting yesterday, a psychologist in my office, I have $100,000 in student debt. Why can't I get the National Health Services Corps to, well, I'm sorry, those slots are already, taken or whatever. So we could certainly use a lot more support for workforce development. Okay, so there's no magic to fix all this. The problems are there, the problems are persistent, and they would be extraordinarily expensive to fix. But telemental health is as closest we have, the closest thing we have to magic in terms of helping to fix this or address this issue. You might think, well, is that really a great idea? Putting some psychotic patient with severe delusional disorders and maybe lots of paranoia in a room with somebody else who's with a TV that's talking to him. Is that really a good idea? You might think that, but actually, and of course, most of us did think that when it first started to be discussed 15, 20 years ago. But it works remarkably well. It really does. Remarkably well. They love it, almost to a person. The patients that I've talked to love it. And the research, the surveys show that as well. There are occasional glitch or two, but it works really well for the most part. So, and obviously, it by definition, the way it's structured, expands access to clinical services in a way that eliminates the need for the $4 a gallon gas for the most part. So. We are working, and I'm going to tell you a little bit about that in a second too, also enhances communication between those 10 to 12 providers that our patients are seeing. So, and I'll come back to that in just a little bit, but the basic key recommendations is things as we've studied this problem, as we continue to do lots of grant writing. That's the other thing that wasn't mentioned in my job description is sort of one of the key grant writers, and we're always looking for resources, always looking for ways to address these problems. So in my mind, everything I hear, every research article I read is part of my statement of need. I'm always incorporating this stuff. I'm writing the next statement of need for the next grant. So these key recommendations really come from sort of our attempts to kind of get our arms around and do a better job of being responsive to the folks that we have responsibility for. And that includes this sort of overarching recommendation of improving healthcare provider and public awareness of effective behavioral health screening and treatment through education, public relations, networking, and overcoming stigma. I mean, that's a mouthful. It's a tall order. But there are ways and means to do this, and we continue to find new ones all the time. We are just got back from National Council Community Behavioral Health Care meeting in Chicago, and it's extraordinary the number of social media presentations being made. Mental health is, in many ways, beginning to embrace it in some fairly extraordinary ways, but we I think, in many ways, have not yet begun to scratch the surface about the tapping into the extraordinary potential of social media for doing some of this. Getting the word out that we have treatments that are effective, and that if you can just get there, we can help you. Ensuring the availability, this is the real, even taller order in many ways, ensuring the availability of a network of behavioral health providers. According to Gustafson, Preston, Hudson, appropriate training for primary care providers may be the first steps toward ensuring rural residents have access to mental health services. As we know, Primary care providers are the de facto mental health care system in this country. And in the few minutes I have left, hasn't gone off yet, talk about something we're working on, a couple things we're working on. One is a Citizens Memorial Hospital healthcare system in Bolivar, one of the best rural healthcare systems in the country. It's been recognized as such. We're very pleased to be working with them. We just knocked down a fairly large HRSA grant with them for rural health outreach, where we're going to be piloting and fielding this intervention of a psychiatric consultation to primary care physicians to really help sort of expand the access there, because for the time being at least, there's just not going to be enough psychiatrists to go around, even in urban areas, let alone to the far-flung rural areas. So we have to find ways and means of supporting the folks who are actually delivering the mental health care in this country, and that's in most cases primary care providers. And this is a remarkable thing, I think. Over 50% of psychiatric care provided by them, actually 65% in rural areas is what the data show. Most of them don't feel adequately trained, and some objective evidence say they're not adequately trained to really properly diagnose and treat these disorders, of course. Up to 70% of primary care residency programs don't even approach the necessary psychiatric training. It's not a psychiatric residency, so you wouldn't necessarily expect them to. But the party line for many primary care providers is you got to be able to treat, say, 90% of what comes through the doors. Well, a lot of that is going to be 40 to 60% of that is going to be driven by emotional and behavioral and mental disorders. ABTEC is our acronym for A Bridge to Effective Care, which we're waiting to hear about a grant proposal. We submitted a $8.3 million grant proposal to the Healthcare Innovation Challenge at CMS to do this thing that we're calling A Bridge to Effective Care, a primary component of which is this very element of getting a psychiatric consultation to primary care physicians in real time to the extent possible, so that when they have folks in their office, or very soon after at least, when they have real-time questions about the care of a psychiatric patient, that they can have real-time support through either a psychologist or a psychiatrist, as the case may be. And we're still working on how that's all going to look in terms of a decision tree and screening and all that. But the implementation will require a couple things: broad-based training and integrated care models, which have been around a while and are being tweaked continuously. And the second thing is immediate access to psychological consultation for these participating primary care providers, either by phone or in person. And, wow, that was 20 minutes on the dot. Amazing. Thank you all very much.
Thank you very much, Dr. Thomlinson. And now welcome our last but not least, our last speaker, Mr. Jeff Lubsen.
Thank you. I was going to sneak in behind you so we could get going. Sorry. I've got an hour presentation that I condensed into 20 minutes, so I'm going to have to talk 3 times as fast to get through this. Try not to, I'm sorry. Just holler out, though, if something isn't maybe registering and you want a little bit of clarification. But basically what I'm going to visit about today is the impact of sexual and gender microaggressions on accessibility to healthcare issues for folks that are lesbian, gay, bisexual, or transgender identified. We're going to talk a little bit about the etiology of microaggressions, some terminology which is foundational a lot of times to microaggressions, social ecologies of our identity, kind of the multiple layers that makes this such a complex issue, and then the chilling effects that microaggressions end up having, which causes barriers to accessibility to healthcare for a number of folks, and then also what providers can do to help that. Sexual or gender microaggressions often occur with the use of assumptive heterosexist terminology, hence the necessity to review some basic terminology, which I wanted to kind of jump right into. The concept of microaggression essentially is this subtle negative connotation or attitude that kind of devalidates or communicates this concept of illegitimacy or delegitimacy in some concept. This was a term that was introduced in the 70s as racial microaggressions, and now we've kind of adopted that terminology for sexual orientation or gender identity microaggressions, which are, again, subtle negative attitudes conveying someone's sexual or gender identity. Heterosexism is the assumption that folks are or should be heterosexual, and what this does is excludes the needs and concerns of LGBT individuals and their families. Homonegativity is kind of this alternative term to homophobia, which really isn't kind of a true term there, right, because that would imply irrational fear, but homonegativity is more about this negative attitude or concept towards homosexual or homosexual identified folks. Heteronormative is this concept of natural or normal roles that differentiates two complementary genders, man or woman, and kind of holds this concept that heterosexuality is the norm. Terminology-wise, LGBT, from a clinical perspective, acknowledging the acronym tells your client that you recognize a spectrum of sexual expression. And the LGBT Affirmative Therapist Guild uses just those 4 words to kind of include this umbrella. But of course, I'm going to show you in a minute how that terminology can continue to include asexual, intersex, two-spirit, allies, queer, and all the other kind of gamut of folks that have different gender and sexual expressions. It's important, though, I think, that we recognize these identities and how each one of those identities have unique health concerns. Sexual and gender minorities is kind of this encompassing term that we use to identify the social disparity within the non-heterosexual identities, which helps us kind of more from a reporting and statistical standpoint. Sexual orientation, again, is this affectional or loving attraction towards another person. This is defined by the APA. But even a term like that excludes the concept of asexuality. So you can see how this becomes more complicated than sometimes we are able to grasp. Gender identity is one's basic sense of how they may identify in terms of gender expression as far as appearance, gender role conformity, or whether or not they feel that they are in a body that's the same with their identity. Sexual behavior is oftentimes different than sexual orientation, so this makes things even more complicated when it comes to reporting, identifying, and also trying to devise outreach to different communities. So this is where you see the kind of the MSM and WSW, men have sex with men, women have sex with women, etc. Gender identity is different than sexual identity. I think it's really important that we recognize that, and one particular maybe example is to look at transgender folks who maybe were ascribed an identity when they were early on in the process of being homosexual, but then realize that it was actually a gender identity issue and now actually identify as, in reality, as heterosexual all along. Gender presentation is oftentimes defined from socially codified gender role expectations. So again, this has more to do with how somebody would present the gender, but doesn't necessarily align with how they might identify. So this is where the kind of the term queer comes into concept, is that this is kind of thought more of a broader movement that challenges the concepts of normalcy and challenges these conventional thoughts of what it means to be norm in a society that really is, you can't go outside of the norm, right? So this idea of freak of nature really doesn't exist because it's an oxymoron, because we are nature. Queer culture in this context embraces differences as uniqueness as opposed to abnormality, which is why that's, I think, an important thing to remember. Transgender is also a term that we're using as all-encompassing term, which identifies a wide variety of gender variant identities from a multiplicitude of a spectrum. So we also call this trans people, trans folks, or trans-identified, and some specifiers, male to female, female to male, just based on our binary gender system that we think of now. Why there are some problematic terms, gay, straight, again, it's just this concept. If you look at the dictionary, straight is defined as kind of proper order, condition, conventional, respectable, live the honest life. These are all actual definitions out of Webster's, so it kind of has these connotations. But you will hear me use that terminology because, quite frankly, it's just much simpler sometimes to refer to gay, straight terminology. So I'm not one of those people that thinks it's bad to use, but I'm just saying these are some of the challenges. Homo heterosexual, it was kind of used as more of a denigrating term that sometimes emphasizes the sexual act, and so it also is tied to the kind of the historic pathologization of LGBT folks. You know, it's just up until '73 in the DSM, it was homosexuality was still listed as a mental health pathology. So again, problematic, but not necessarily a hard, fast rule not to use. Transsexual, hermaphrodite, transvestite. Now this is, unless you understand the differences, I think it's really important to be careful with your use of the terms. First of all, hermaphrodite, right off the bat, is an antiquated term, not appropriate. Intersex is a more appropriate term today. Transsexual is somebody who's going to be generally post-operative, or somebody who actually has been realigned by gender surgery. Transvestite tends to be more of what we think of as cross-dresser, or somebody who might be autogynephilic, which is a sense of themselves as an opposite, or of the opposite gender. Gets a little more complicated than that, but we're going to run out of time if I don't move forward. Transgendered, again, is this kind of concept that maybe is not as appropriate as transgender, because again it has this idea of something that's been actively done to the person. So let's take a look at our social ecology of sexual and gender identities. This is how it gets to be a little more complicated, and I wanted to kind of jump into this. Lesbian, gay, bisexual, transgender, queer, questioning, asexual, allies, intersex, two-spirit, and the acronym can go on, right? Within that, though, this is where it starts to get really interesting. If we look at Bronfenbrenner's social ecology theory or any of these kinds of systems-based theories, look at how complicated it can really start to get. Now you can get into gender identity within that. So a lesbian who may identify as masculine, feminine. Boy, I'm not going to remember these terms. I don't remember what they were. Gender presentation may be butch, femme, queer, androgynous. Relationship expression may be monogamous, polyamorous, polyfidelicious. Relationship dynamics may be assertive. I can't remember how I came up with those. Orientation fluidity, again, this idea that somebody's orientation may not always be consistent throughout their lifetime. And then how they may express themselves sexually through different forms of sexual expression. So you can see how these layers of identity can really get complicated, and this is why I think it's important to recognize that there's a vast number of cultural identities to take into account when we think of disparities in LGBT populations. Really in all populations, right? But it's just, I think the LGBT folks are the ones who've thought about this stuff, but really heterosexuals also have these very broad array of identities. So in response to it, a lot of times I hear, why is there a need to focus on LGBT issues? Or I'm a practitioner who doesn't work with LGBT people, but the one undeniable fact about sexual variability in the world is just the odds dictate that everyone is going to be involved with LGBT individuals in some manner. A lot of times they're going to be, this is an invisible situation, so they're going to be people who may not be out, they may be hiding, they may not be aware of their identity, or they may still be developing. The biggest one, of course, are going to be friends and family members of folks in these degrees of separation. So these are issues that do affect all of us, regardless. And the important thing to remember is that the invisibility can also lead to increased misunderstanding and therefore increased microaggression potential. So the chilling effects of microaggressions impairs accessibility to health care. And this is a recent study by Shelton and Delgado in Journal of Counseling Psychology last year, where it's just kind of starting to come online, where we're understanding how there are certain themes of sexual or gender orientation microaggressions that may kind of be bleeding into the mental health clinical environment. The first thing that they identified is the assumption that sexual orientation is the cause of all presenting issues. Again, this is the idea that I think we sometimes forget that mental health issues or mental health illness may be in response to the way the individual was treated. So again, it could be due to the disparity, not necessarily due to the identity, and this is where it becomes problematic. Just like racial issues, just like a lot of other problems that you see in disparities, the problems are the result oftentimes of the response to the issue, not the issue itself. Avoidance and minimizing of sexual orientation, again, this is that kind of invisibility aspect, not acknowledging the acronym, not understanding the complexity of the layers of identity just contributes to this kind of silencing effect. Attempts to over-identify with LGBTQ clients, again, that can be problematic because it's this basic cultural competency. I think we're talking about kind of that 101 multicultural competency concept. If you haven't experienced or lived, sometimes you can't read about some of these issues, right? There's an aspect that has to be experienced and lived and has to come from a different concept that's more applied and practical and not just theoretical. And then making stereotypical assumptions about clients. Again, stereotypes become a very narrowing effect with your client rather than a broadening effect, which tends to confine rather than, or define rather than help the individual explore deeper. Expressions of heteronormative bias. Again, this is going to be our most common, I think, microaggression where folks make assumptive terminology, and we use in our forms. We're going to have, all the different language kind of issues with that tend to be heteronormative. Assumption that LGBTQ individuals need psychotherapeutic treatment. Again, there may be some needs for treatment, but the treatment may be in response to an issue, or there may not be a necessarily specific tie especially therapeutic treatment, may not be tied to the coming out process or anything that has to do with their identity. It may be, again, in response to some of these secondary and tertiary responses or effects of that. Warnings about the dangers of identifying as LGBTQ. Again, this would be kind of the typical political correct statement that, well, I'm supposed to say this, but, you know, I've got a cousin or an uncle that this, and this is what their life's like. And this is also kind of a current trend that you're seeing. New York Times had some recent articles about therapists who are encouraging or helping their clients stay in the closet. And there's, I think, a certain side that there's a dilemma there, right, with a therapist, because we also want to work within our client's worldview and where they're at, but at the same sense, we want to make sure that we're also looking out for their best interest as far as making sure that they understand all of the options that are out there. So 3 really fast case studies. These are just my clients, and I haven't even been in practice for more than a year, and so just within my clients, I have a 32-year-old female disclosed to a provider this kind of immense pain around breakup with her first girlfriend, and the licensed therapist moralized that and kind of, this is what you get for being queer. 29-year-old male grew up in rural Kansas, disclosed to the provider he thought he might be gay, and the licensed therapist again encouraged the client to pray away the gay in their office together. This was 1985, but I have the older client, 15-year-old at the time, grew up in rural Iowa, identified as gay, pretty well adjusted at the time, had some allies and some cousins who were good role models, and then went to a psychologist looking for an ally or kind of some support because it was rural Iowa, and that therapist's brother had just been diagnosed with AIDS because it was 1985, so it was actual AIDS, and the client, he kind of projected and counter-transferred these issues then onto this client that this will be your life as well. Those were real stories, and that's just a small little percentage, so it's a real problem. Here's talk a little bit about kind of how this impacts the barrier to accessibility. When you see this systematic erasure of LGBT identities, then it happens on kind of 2 levels. This informational erasure, where research, information synthesis, and curricular training kind of misses out on that whole aspect, and then this institutional erasure, where policies and practices it's just not there. So when you have this erasure, it ends up kind of having an in turn kind of cyclical effect, where we don't have the data to support, we don't have the studies, we don't have a lot of the understanding then to go on and move forward with understanding these problems. This becomes part of the challenge. Part of the reasons that in some of the research of why folks felt that they didn't want to disclose to their healthcare providers, some felt that it wasn't relevant, although relevancy is not always transparent. There was a fear of negative judgment, awkwardness with a practitioner, lack of understanding, humility, fear of loss of confidentiality that the physician might report to insurance staff or other folks, and then just feared poor treatment outcomes based off of biased assumptions or discriminations. Some of the reasons, in turn, why some of these folks wanted to come out to their providers are that they would like to be asked but didn't want to have to bring it up themselves. They'd like to be seen as a whole person, as who they are. They wanted to increase their comfort levels regarding their identity, increase chances of proper diagnosis with relevant information provided and appropriate referrals, and so that providers will be sensitive to the issues they're facing. Challenges faced by LGBT clients: less likely to disclose to healthcare providers because of biased assumptions and poor treatment, equating sexuality to a sex act versus identity. That's a big one. Not receiving safer sex info for both male and female partners because there's an assumption, again, kind of forgetting about fluidity or the possibility of multiple of partners of either gender. LGBT as being viewed as part of their health problem, placing blame on the identity, and moralizing or judgment surrounding the identity. Those tend to be some of the common ones. Part of the misunderstanding, I'm just going to move ahead of that. So the effect that this has is the lack of safety to disclose within healthcare contributes to healthcare avoidance and poor care-seeking behavior. Previous negative or inadequate experiences oftentimes make clients skeptical to return to the healthcare system. So this results in missed screenings, later intervention, and can have a kind of a cascading effect. The assumption that everyone in the practice is straight kind of creates this non-welcome or unsafe feeling, especially since it is a stigmatized topic. Not being asked about your sexual identity, again, may just come across as a silencing kind of unwelcoming or hostile environment. So even when providers don't just demonstrate negative attitudes, so they may not have be consciously aware of microaggressions. They may still be lacking in the education needed to work well with these clients. Again, part of this is just there's a lack of research because of that erasure that we talked about a minute ago, and the institutionalized concept of heterosexism, transphobia, and biphobia continue to remain a barrier of care to folks within LGBT identities as well. Sorry, I'm blowing through these, but I had a ton of slides, and I wanted to get to some of the good stuff a little bit later. Again, sexual fluidity is off the radar for some providers. There's barriers to substance abuse treatment services because some of them aren't geared towards the particular folks that are in the LGBT spectrum. Sometimes provider hostility or insensitivity, strict binary gender segregation within programs, and sometimes just a lack of acceptance in gender-appropriate recovery groups. The effects on accessibility starts when you're young. LGBT folks are at increased risk. A number of studies for alcohol, suicide, you kind of name the gamut. There's a higher rate of mental illness, and again, this is probably in response to the stigmatization and the disparity. Current interventions not geared towards the unique problems that are faced by LGBT clients. For example, there is some substance abuse prevention programming by SAMHSA. There are some other ones out there through Fenway and some other great organizations, but a lot of it's not getting into the provider hands, and it's just not out in the fields for a lot of these folks to have something that's targeted specifically for them. How the provider's knowledge impacts healthcare, not only, for example, these are just kind of some quick examples, not only increased risk of like sexually transmitted infections, but also increased risk of cancers, so there may be a lot of folks that's not on their radar. Screening intervention for elevated suicide, depression, anxiety, substance abuse, tobacco use, because those are all known to be at higher risks within the community, within LGBT populations. Eating disorders among LGBT folks, oftentimes we think of it as a heterosexual female problem, but actually it tends to be the highest with gay men. Bulimia and anorexia are very high in gay men, and then we also just see eating disorders with lesbian, bisexual, and trans folks as well. Again, this is kind of an example of how do we determine when disclosure is pertinent. 4 more case studies. Again, these are just happen to be my clients of a very short time, and I already have 4 great stories. One was a 20-year-old male who's gender conforming, went to the student health center. So gender conforming meaning kind of came across as heterosexual. Had a sore throat. The provider didn't bother really talking about sexual history and just directly gave him the antibiotics for strep, which does not treat chlamydia. So oral chlamydia was the situation here. He got worse. It was 3 to 4 weeks into it. Actually became kind of serious before it actually was caught. Great example of a missed intervention. 23-year-old male with discharge was moralized that this is, again, this kind of this moralized concept, this is what you get, and was not treated very well. 29-year-old male, never occurred to get an HPV anal pap. We're finding HPV is this kind of hidden thing that's really starting to emerge, especially nasal and oral as well as anal HPV. So it really elevated risk within HIV populations. So this is something that was kind of off the radar, never got screened, and then by the time it was caught, it was quite bad. It required several surgeries. 35-year-old gay male who had a colonoscopy just because of some intestinal issues was at the LDS hospital in Utah, which was kind of focused on a Mormon belief system. Feared disclosing because of that, and it wasn't until just before having the procedure done that one of the fellows came in that was a little bit younger, and I think he was able to relate to him better. And was able to disclose to the fellow. So this is just a good example of how sometimes this disclosure may occur with staff or with other folks within the system wherever there's this perceived safety. What can providers do? This was the good stuff I wanted to rush to, and I've got 4 minutes left, so we'll blow through there. Again, Fenway's Guide to LGBT Health talks about the more different clinicians perceive themselves to be from their patients and vice versa, the more likely it is that either or both parties will feel uncomfortable during clinical interactions. Providers need a basic understanding of those layers of gender and sexual identities so that we understand that there is a range of issues here and that there is legitimate disparity within those populations. There's a need to recognize how those LGBT identities are not just about sex or gender roles, but these are deeper identities that have a cultural, enriched baseline to who somebody is. It's not just about sex. Identities are important, therefore, because the individual, even if the individual is not in a relationship or being sexually active. Each identity within the LGBT spectrum has unique health issues, as we talked about a second ago. Visible inclusion in public health services with programs focused on specific needs to LGBT clients. I think validate is a big thing that mental health folks can do, validating clients' identities, viewpoints, and concerns. I always encourage folks that if you feel uncomfortable working with LGBT-identified folks to refer. I think that's appropriate. I also think because microaggressions really are dealing with this deeper response to political correctness, right? You can have this political correct response, but clients can still read through the subtle negative kind of discomfort there. So I think being disclosing and being straightforward with clients is a great way to kind of help overcome that. Let clients know that this is something maybe you haven't worked with, but you want to understand that you want to treat them fairly. Just validate and reaffirm. Specific education for providers and staff, I think, is critical for this community. My other half is in med school, and I think they get a total of 5 hours, their entire curriculum for LGBT issues, or just sexual issues in general, it sounds like, other than GI. Healthcare providers serving as advocates for community partnerships that will enhance a connection of LGBT folks to society, communities, and spiritual communities. I think there's this real kind of disenfranchisement that you see in any disparate population, right? So reconnecting folks to society, to the community, and to other spiritual communities is really important. That's why the Guild and our website, we have ties to spiritual connections and all kinds of other great resources, because it's all a part of reconnecting to that resilience-based strength model. Specific outreach targeting at-risk LGBT folks within minorities, also LGBT youth, LGBT elderly and aging, and trans-identified tend to have higher risks. Guidelines on multicultural competency, I think, is a great way to start, and we understand that being a multicultural competent provider starts with your own understanding of your own cultural worldview and your own biases. It has a foundation of respect towards cultural differences and understanding cultural plurality, meaning more than one correct or right way of doing things, developing skills and addressing and negotiating cultural differences in a respectful and dignified manner, I think are all super important. There is some literature out there that talks about specific ways in which you could be friendlier towards LGBT clients, gender-neutral terminology, especially if you're unsure about how to address somebody, ask them politely, keeping the terminology neutral on intake forms and whatnot. Staff training, again, this is what happens is a lot of times that gets to the provider, but it doesn't get to the staff members, and that's where a lot of these microaggressions are occurring. So this is where it's really important to have this all-encompassing systems-based training for the front desk staff all the way back to the MAs to the providers. Non-discrimination policies that are intact, that are very clear and that are being enforced. And then just doing some simple things, brochures, posters, lobby materials that just kind of guide this concept that you're an LGBT-friendly place helps kind of make up for that disparity. And then advocating within local LGBT organizations, I think, is important, just being connected to those organizations and working from that kind of participatory, action research-based kind of model. Why it's important to recognize the complexity of this, perhaps we need to rethink how we think. Again, difference as uniqueness rather than abnormality, and this is where that challenge kind of comes into, that perhaps the queer movement, again, this idea that's pushing against normalcy, is trying to teach us that we as humans do not need to possess prefabricated ideas of what gender identity or sexual expressivity should look like or behave like, and instead simply nurture and appreciate these variations of identities as a part of a broad spectrum of human expression, free from judgment. And again, these are just a couple of examples. Andrei Prejic, which is a supermodel right now that is both able to, in both female and male publications. Thomas Beatty, who is first legal man who is able to, who's transgender, F to M, who is able to actually carry several children to term. And then alternative relationship styles that may go beyond just binary two-person relationships. And I think that was it. And I made it right on time.
Thank you very much. And now if we can open for questions. I think our time is a little bit limited right now, and lunch is going to start soon. But if you have a couple of questions, that would be great. And I see one. Let me just...
Expect my voice to be super loud. You're kind of touching on my shtick, so I was really excited. I'm very interested in LGBTQ mental health, and I'm really glad that you covered so many different terminology, even though it's a deluge in the end. It's really hard to avoid because there's so many terms. I just kind of want to put in a little plug. I'm on the board of the Association of Gay and Lesbian Psychiatrists, and we have a fantastic mental health syllabus called the LGBT Mental Health Syllabus, and it's on our website. It's completely free, so it's at aglp.org. It provides a history of psychiatry's tumultuous relationship with homosexuality specifically, but of course any kind of sexual or gender difference has been sort of a problem, as well as best practices and recommendations. So as a kind of great clearinghouse from the medical psychiatric community, I think it can be really useful. So
great, let's connect.
Oh yeah, absolutely. Thanks.
And we have a second here, and then here.
Dr. Thomlinson, you spoke to a lot of issues I'm really passionate about with the GLBT community. Is there anything in Columbia where I can help out with STD prevention or something like that?
Were you talking to me?
Yes.
Okay, Jeff. Sorry, this is Dr. Thomlinson.
Oh, I apologize. She told me you were Dr. Thomlinson.
I'm sorry. One more time.
Is there any place in Columbia where I can go and help out with STD prevention, either as an intern or as a paid position?
Good question. Let's also connect offline.
Okay.
I want to direct this to Dr. Parks. Dr. Parks, can you give me well, I've got two questions, actually. How much has the Department of Mental Health revenue or money gone down in the last 15 years?
I don't have that on the top of my head.
It's pretty significant, though, correct?
The state revenue has gone down significantly. The total revenue, federal and state, has stayed about even.
Okay. My second question has to do with when you use the term schizophrenic. When you were talking about the health disparities for those folks, were you really talking about people who are diagnosed with schizophrenia, or were you talking about people who might be on antipsychotics that could be either schizoaffective, bipolar? I mean, because there's so much crossover in those diagnoses.
I talked about several different populations. The original mortality study was, the identified population was people in service with the Department of Mental Health in that state. Whatever reason, whatever diagnosis, some of them undoubtedly were people with schizophrenia. Some of them might have been somebody that got a crisis service once. But getting in that population meant you were an open enrollment in that state's mental health system. For the slide on Katie, those were all people with research diagnostic criteria schizophrenia, which is much narrower than a billing diagnosis for schizophrenia. So, it depended on the slide and the study. We could go over and, I could answer about any particular one, but it was a range of different mental illness people, populations with different ways of being identified as having mental illness as an issue.
And then just a comment, I do a lot in my personal life related to mental health. My professional life is more health. I want to put a plug in for NAMI, National Alliance of the Mentally Ill. I think in this economy where diminishing resources are absolutely happening, that we need to figure out, we need to get families and consumers hooked up with organizations. NAMI is very cost effective. I mean, it is family members, it is consumers who are volunteering their time. It doesn't cost anything, and they can probably help that family member or others almost more than psychiatrists, psychologists, and all of that.
They have an excellent and informative website that has links to many other sources of information. So they are very much worth checking out, both as an organization and information source. The other organization that also does advocacy and would be worth looking into, but is not as active in your area, is the Mental Health America. But the NAMI chapter is much more active here.
Do we have any other questions? Right. And this is going to be the last question.
Dr. Parks and Dr. Burrell. I have a question for you. Are there any current resources for patients with mental illness outside that the primary care physician can connect them with as a support group, which may kind of augment their healing with mental illness?
Actually, NAMI does excellent services for people with mental illness, not just their families, and provides support groups for them also. That would be a good place to start. Many of the treatment agencies, such as Burrell in town, also can put you in touch with support groups around town. There's several. Some are diagnostic specific, some are more general. Paul, do you have anything to add?
That was what I was going to say.
Yeah. Those would be your two main sources. Mental Health America is here. They're out in the lobby. So just in terms of equal time, they both do excellent work, excellent advocacy, and have very good resources to offer. And you should use both of them and go to all their meetings and pay all their membership fees. So why go with one when you can have two?
Yeah. Thank you very much. And can we give a round of applause again to our speakers?